about the conduction system of the heart. Conduction system of the heart is more like an electrical system of the heart. As we see that we push the button and the current flows through a certain circuit, and then it reaches the end point. It can be a refrigerator, it can be air conditioning system, it can be a fan, it can be a bulb. So when we push the button, the electrical current flows through a certain circuit and reaches the end point and causes it to either work or just glow. So in the same manner works the conduction system of the heart, where there is a starting point, then there is a receiving end, and there are certain channels or the circuits through which this current flows. So let's talk about the conduction system of the heart, and then we will see what is its pathologies, what are the positive and downsides of the electrical conduction pathway or the system of the heart. Let's talk about it. So today this is going to be the conduction system of the heart. Conduction system of heart. First of all, let's talk about the anatomy of the conduction system. Let's draw it here. These are two atrias, and these two are the ventricles. Let's name all these things. This is sinoatrial node, famously known as SA node. This is SA node. These are internodal tracts. This is the posterior, middle and anterior. These are internodal tracts. And this is a Bachmann tract. This is a Bachmann tract. Okay. And this node is known as the AV node or atrioventricular node. Atrioventricular node. Here comes underneath AV node is this strip is the bundle of His. This one is, this thing is bundle of His. Bundle of His. Here comes right bundle branch. This one is right bundle branch, and this is left bundle branch. Left bundle branch. And this is the posterior vesicle, this is anterior vesicle. And these fibers at the end of these vesicle and bundle branch are known as Purkinje fibers. Purkinje fibers. This is posterior vesicle. This is anterior vesicle of left bundle branch. So let me write down here. This is posterior vesicle and this is anterior vesicle. Anterior vesicle. Okay, let's talk about the anatomy of the conduction system of the heart. The anatomy of the conduction system of the heart starts from sinoatrial node or SA node. SA node is anatomically located in the right atrium at the point where superior vena cava is actually entering the right atrium. Here, from the SA node, three internodal tracts, they move towards the atrioventricular node. This is anterior, this is middle, and this is posterior internodal tract. And from SA node, another tract goes towards the left atrium, which is known as Bachman tract. Atrioventricular node is another node which is located at the junction of the both atria and the ventricles. And from the AV node, there is another tract underneath or a fibrous tissue which we call bundle of His. And this bundle of His gives off mainly three branches. One is the septal branch, which goes to the septum. One is the right bundle branch, which goes to the right ventricle. And one is the major left bundle branch, which then further subdivides into the left posterior vesicle and the left anterior vesicle. If you can recall from the anatomy of the heart, the left ventricle of the heart is a larger ventricle. The right ventricle is a smaller one. Right ventricle acts more like a pocket. It doesn't store the blood. It doesn't host the blood. It more works like a conduit. It lets the blood pass through it. So the larger ventricle is the left ventricle. It has got a more muscle mass as compared to the right ventricle. So it has got two sub branches of the left bundle branch, left posterior vesicle and the left anterior vesicle. Now these left posterior vesicle and the anterior vesicle and the right bundle branch have got certain fibers at their end. These fibers known as Purkinje fibers. These are the last part of the conduction system which are embedded into the ventricular muscles. So it all started from anatomically from the SA node and it's ending all the way up to the Purkinje fiber. So this is the anatomy of the conduction system of the heart. Now let's see what is the physiology of the conduction system of the heart. Now, talking about the physiology of the heart, it all starts from the SA node. Impulse transmission starts from SA node. How? From where it comes to the SA node. SA node or the sinoatrial node automatically fires. Nobody or nothing asks it to fire, but it has an inherent capacity to fire impulses at a rate of 60 to 90 times per minute. 60 to 90 times per minute it fire impulses which actually from the SA node go to the left atrium through the Bachman tract and they enter the right atrium through the internodal tracts. Now from the Bachman tract it goes to the left atrium and through the internodal tracts while passing through the right atrium they enter the AV node. So these impulses which were automatically fired by the SA node while passing through the atria, they cause the atrial muscle to depolarize. And this depolarization of the atrial muscle generates P wave. This wave is known as P wave. The first positive deflection is generated by the P wave, by the atrial depolarization of the both atrial muscle. Now from the atria through the Bachman tract and internodal tracts, this is the anterior, middle and posterior. It enters into the AV node where its transmission is delayed for a brief period of the time so that both the atria and the ventricle, they can depolarize or in a certain rhythm. So here it causes a delay which we have on the ECG paper as PR segment. PR segment is that part of the ECG which starts from the end of the P wave to the start of QRS complex. This is known as PR segment. This thing is known as PR segment. This is called PR segment, and this is the very time when impulse is passing through AV node, and the passing of the impulse through the AV node causes a little bit of the delay which we see as a PR segment. From the AV node, this impulse enters into the bundle of His, and here it again speeds up, and the bundle of His goes into the three branches. One is the septal branch, then one is the right bundle branch, one is the left bundle branch which has got two posterior and the anterior vesicles. This septum is depolarized first, and then through these branches which have got Purkinje fibers at their end, there is depolarization of the both ventricular muscles. So depolarization of the septum causes a first downward deflection which we call the physiological Q wave. The first downward deflection is known as Q wave, and then the ventricular muscle, they depolarize almost simultaneously. Both the right and the left ventricle, they almost simultaneously depolarize to cause the generation of a very fine morphology known as R and S. QRS is caused by the simultaneous depolarization of both the right and the left ventricle. Septal depolarization causes a formation of a very small Q wave. Then comes the complete depolarization of the whole ventricular muscles, right and the left, almost at the same time, which causes the formation of a tall R wave. The tall R wave. And at the end of this, the wave of depolarization goes from the epicardium down towards the endocardium. R was formed because the wave of depolarization was coming from down towards outside. So the leads saw it coming towards them and they generated a tall R wave. But at the end of this transmission, the wave of depolarization is going from the towards the is going away from it. Now this time around it's going, the last part of the muscles which are depolarized in the ventricles are the one located very near to this fibrous tissue which divides both the atria and the ventricles from each other, or separates from each other. So it generates a very small S wave, downward deflection S wave. Then comes a J point which connects this straight line with the S wave. So this is Q wave, this is R, and this is S. So the QRS complex is generated by the depolarization of the ventricle. Let's stop here because our conduction system has done its job physiologically. So what is the physiology of the conduction system normally? Sinus node automatically generates impulses at a rate of 60 to 90 times per minute. They enter into the both atria through the Bachman tract and internodal tracts. Cause them to depolarize, which generates a P wave on the ECG paper. Then it enters into the AV node where it is delayed for a very brief period of time, and it causes the formation of the PR segment on the ECG paper. From the AV node, it enters into the bundle of His and then goes into the three branches: septal, right bundle branch, and the left bundle branch, which have got Purkinje fiber at their end, and then it enters into the myocardial cells, causes them to depolarize, which generates QRS complexes. Now the PR segment is the very time when a impulse is passing through the AV node, but PR interval is from the start of the P wave to the start of QRS complex, and it is the time when sinus node is started firing impulses, atria is depolarizing, and then AV node it has entered into the AV node. So before the depolarization of the myocardial cells are the ventricular myocardium is PR interval from the start of P wave to the start of QRS complex, but PR segment is from the end of P wave to the start of QRS complex, and this denotes or this signifies the very time when impulse is passing through the AV node. So this is the normal physiology of the conduction system of the heart. So let's talk about the pathological condition which are associated with the conduction system of the heart, starting from the SA node. Now there are certain conditions which are associated with the SA node. SA node pathologies are: number 1, sinus tachycardia. Sinus tachycardia in cases of anxiety, fear, fever, and adrenaline rush, hyperthyroidism. Number 2, this can be sinus node reentrant tachycardia. Reentrant tachycardia. There can be sinus bradycardia. Sinus bradycardia. There can be sinus arrest, where sinus node fails to fire at all. Sinus arrest, sinus pauses. Sinus pauses. So these are the pathological conditions which are associated with the sinus node. We are going to talk about the pathological or abnormal or semi-abnormal conditions which are associated to the conduction system of the heart. The first of all, it is the sinus node. It can be sinus tachycardia, sinus node reentrant tachycardia, sinus bradycardia, sinus arrest or sinus pauses. This is sinus node problems. Down comes the atrial problems. Why we are going to include the atrial problems into the problems of the conduction system of the heart? Because from the atria they ultimately enter into the AV node. They are to pass through the conduction system, though they have got their origin not within the conduction system but outside of it. So what are the problems of this part of the heart, atrial problems? So let's talk about the atrial pathologies which are ultimately associated with the conduction system of the heart. One is atrial tachycardia. Second is atrial fibrillation. Third is atrial flutter. And the fourth one is multifocal atrial tachycardia. So these are the abnormal conditions or pathologies which are somehow associated with the conduction system of the heart, because irrespective of their origin, they ultimately gain entry from one part of the heart, like the atrium, to the other part of the heart, ventricle, through the conduction system. So these are atrial tachycardia, atrial fibrillation, atrial flutter, a multifocal atrial tachycardia. Then comes the AV node. There are some problems associated with the AV node. This is the AV node. So there are some problems which are associated with the AV nodes. And what are those? Let's talk about them. AV nodal problems. AV node. Very famously, we know that sometimes AV node has got some problem with the impulse transmission down the ventricle. It starts playing with its role. It starts exploiting its role to let the impulse pass through it. It delays it sometime and causes the first degree AV block. First degree AV block. Then comes the second degree AV block. Second degree AV block. Both types, type 1, Mobitz type 1, which we call Wenckebach phenomena, and Mobitz type 2, which we call Mobitz type 2A. Third is the third degree heart block. Third degree heart block. Actually, these heart blocks are AV blocks. Third degree heart block. Because physiologically, AV node has got the role of letting the impulse pass through it, though a bit delayed. But here it starts playing a negative role in its actual allowing the impulse to transmit through it. Sometimes it delays it more than usual and causes the first degree AV block. Sometimes it lets 3 or 4 impulses pass through it, gradually increasing their time period, but ultimately stopping one, which causes the second degree type 1 or the Wenckebach phenomena. And sometimes it becomes even more mad and doesn't let every second or third impulse pass through it. That is known as the second degree Mobitz type 2. And sometimes it shuts down. It stops allowing the impulse passing through it. It has become more mad. It has become sort of like it starts stopping all the impulses passing through it and causes the third degree AV block. So these are the diseases related directly with the AV block. Now there are some problems which may be associated with the AV node, though may have an origin somewhere else down, like in the ventricle. This is what we call AV nodal reentrant tachycardia. AV nodal reentrant tachycardia. Here, AV node has got another tract, another accessory pathway, and after the impulse has gone down to the ventricle, it comes back through that accessory pathway and causes the heart rate to double or more than double. This is known as AV nodal reentrant tachycardia, and there is another disease we call AV reentrant tachycardia. This is again a disease which is associated somehow with the AV node. How? Impulse is generated in the SA node, passes down to the AV node to the ventricle, but ventricle has got another accessory pathway, though not into the AV node, somewhere here, not very near to the AV node. And through that pathway, either it goes back or comes forward and goes back through the AV node. So this is known as AV reentrant tachycardia as opposed to the AV nodal reentrant tachycardia. So these two again pathologies are associated directly with the AV node. Then comes the bundle branches. What are the pathologies associated with the bundle branches? There are very famous bundle branches pathologies, and these are, let me write it, bundle branches. So there are, what are the pathologies? One is right bundle branch block. One is left bundle branch block. The third one is left anterior vesicular block. One is the last one is the left posterior vesicular block. And associated with the right bundle branch block and vesicular block is the trivesicular block. Trivesicular block. So there are certain pathologies. There are certain pathologies which are associated with the bundle branches. There are certain pathologies which are associated with these branches. One is right bundle branch block, where there is a blockage in the transmission of impulse through the right bundle branch. Then there is left bundle branch block, where there is blockage in the impulse transmission to the left bundle branch block. Then there is left anterior vesicular block, where there is a block in the left anterior vesicle. Then there is a block of the left posterior vesicle, where there is a block or there is some obstruction in the left posterior vesicle. And sometimes right bundle branch block is associated with either of the vesicular block, which is known as trivesicular block. So these are the pathologies which are associated with the bundle branch, and all in all we have seen there are pathologies which are associated with the conduction system of the heart. Now we will see what are the drugs which can affect the conduction system of the heart. Now we are going to talk about pharmacological association of the certain drugs which are somehow associated with the AV conduction system. Are there any medications in a doctor's life which are associated, which have got something to do with the conduction system of the heart? Yes, there are. Let's see what are these major drugs. One very famous medication is the atropine. One very important point about the conduction system of the heart is, though it generates impulses on its own, it automatically does so. But this SNode, though it automatically generates the impulses, but it is affected by the sympathetic and the parasympathetic system of the heart. When the sympathetic system of the heart is activated, then the SNode fires more impulses as compared to the normal 60 to 90 times per minute. For example, when you are chased by a dog, or you are hit by something, you are attacked by somewhere, by some side, then your adrenergic system drives you into the fight or flight mode. So because of the over discharge of the sympathetic system, you develop tachycardia. Whenever you are frightened, your sympathetic system gets control on the autonomic system, so it drives the SNode faster and faster because to meet the demands of the body. So the tachycardia meets the demands of the body. But in cases when you are sleeping, your sympathetic system is not that activated and your parasympathetic system takes over. It causes bradycardia. SNode firing impulses rate drops to less than the normal, even it goes up till the like 40. And so sympathetic and parasympathetic system have their own respective effect on the conduction system of the heart, be it on the sinus node, be it on the AV node. So atropine is a vagolytic drug. It causes the blockage of the parasympathetic activity to the SNode, and the sympathetic activity feels itself uncompeted, and it causes the SNode to fires more and more impulses. So that is why whenever you see a patient in the bradycardia and the patient has especially got low blood pressure, is getting hemodynamically unstable, you give atropine, because it is a vagolytic drug. it causes the vagus nerve to stop, either affecting the SA node. Then SA node actually over fires under the effect of sympathetic drug control. So atropine is one such drug which acts on the SA node. Now, then there are very famous drugs which actually act on the AV node. For example, we have amiodarone or amiodarone, whatever you can pronunciate. How you can pronounce it, it's up to you. It is known as amiodarone or the amiodarone. Then digoxins, then beta blockers, then calcium channel blockers. So these are the types of the drugs. Digoxin, beta blockers, calcium channel blocker, and amiodarone, which actually block or they negatively affect AV node. They are AV nodal blocking drugs. How they block it? They have their effect on the refractory period of the AV node. They prolong the refractory period of the AV node, and so they delay or they decrease the number of impulses passing through the AV node, and this is how they cause the bradycardia. For example, in case of the SV node, supraventricular tachycardias, why we use calcium channel blockers and the beta blockers? Because they somehow they maneuver the AV node functioning by acting on its refractory period, and this is how they drop the rate in supraventricular tachycardia. So these are type of the drug which have got their effect on the AV node. Atropine is one of the kind of the drug which has got its effect on the SA node. So conduction system of the heart is very important. Knowing the physiology, pathology, anatomy, and the pharmacological drugs which are having its effect on this conduction system is very important for a doctor to understand.